The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies. But I could. Big Pharma, where you at? But, alas, I have no financial disclosures. Okay, on with the show. Hey, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. We've made it to the letter N in our Alphabet Soup series, which is dragging on for a long time, but that's okay with me because it always gives me a source of ideas for topics. So I'm talking about neuropathy today. I've been considering doing an episode on neuropathy for a long time, but I've honestly been avoiding it because I knew it would be complicated. And it is. Of course, as usual, I'm going to try to boil it down and make it more concise. But there is a lot to it. There's a lot that I don't think about just in dealing with it day to day in clinical practice. Because it is super common, right? We see patients a lot who have neuropathy. And in my case, some of that is new onset. Let's try to figure out why you have neuropathy. A lot of it is you've had neuropathy forever and how do we control your pain. But overall, pretty common. According to JAMA, it affects up to 7% of the general adult population. That increases to up to 10% of the general population over age 60 and 13% in those over age 80. As you might expect in Western populations, the most common underlying cause is diabetes, which accounts for over half of cases. However, anywhere from a quarter to almost half of cases remain idiopathic. And I would say that is consistent with what I've seen in my clinical practice. Some people just have neuropathy and we don't know why. And it's weird and frustrating because it's like, you're probably overlooking something, missing something, but you can't give them an answer. And I try not to just let that ride, right? Some people are pretty good at just telling you, yeah, well, I just have this thing and nobody knows why and I just live with it. And it's real easy to accept that answer. The easiest thing to do in that situation is nod your head and commiserate with them for a minute and then move on. And sometimes that is appropriate, but I try to not be the person who overlooks something that I could have addressed. So with most things like that, I try to at least spend a little time racking my brain and banging my head against the wall to try to think of something else that we could potentially rule out, some other kind of test we could do to get people an answer about what's going on. And that's certainly true for a lot of neuropathy. I'm going to start by just talking about how I typically think about neuropathy and how it comes up in my daily practice and what I do. And then I'll get into all the deeper stuff that I don't think about, but probably should, or didn't even know. So this is just Jody. Anytime a patient describes their pain as burning, or if they describe paresthesia kind of situations, right, numbness, tingling, my mind just goes to nerve pain, whether it's neuropathy per se or something else that's affecting a nerve. That tends to be what people say when they have pain that you would think of as nervy type pain. So usually in my head, that breaks down to, okay, there's something putting pressure on a nerve, either in your neck or your back or in one of the joints, especially the shoulder. It's shingles, you have some kind of vitamin deficiency, or you have neuropathy. And then I try to narrow my testing down from there based on which I think is most likely. Usually I'm going with a nerve conduction study if I'm a bit less sure about the underlying cause, or if I'm pretty sure it's coming from the neck or the back, I'll just go ahead and order MRIs of the C-spine or L-spine. Usually cervical or lumbar. Occasionally I'll do a thoracic spine, just based on the dermatome distribution of the symptoms. But I find that nerve conduction studies are probably the most useful because they can not only tell you, hey, this is peripheral neuropathy versus something further up the chain, but they can identify where it's coming from, right? They can tell you, oh, this is coming from the neck, this is coming from a joint, etc. My personal treatment algorithm doesn't really differ from the published information, so I'll just talk about all that later. So that's pretty much what it boils down to in my head, just in day-to-day work. Here's all the other stuff that I don't tend to think about that's not at top of mind when I'm talking to patients. You can actually classify neuropathy based on several different factors, those being its anatomic pattern, the underlying pathophysiology, nerve fiber type that's affected, or temporal course. So with anatomic patterns, you're looking for, obviously, what parts are affected. So do we have distal symmetric kind of neuropathy, as in the whole stocking glove situation? Is it asymmetric? Is there a proximal pattern that would point us toward different individual causes? With pathophysiology, you're breaking that down into axonal, which demonstrates reduced amplitudes on your nerve conduction study, or demyelination, which demonstrates slowed conduction or a complete block in conduction of the nerve impulses, and that can tell you which direction to go. With fiber type, you're talking about large fibers versus small fibers. So large fibers are those that have something to do with vibration, proprioception, and reflexes, while small fibers are the ones that have more to do with pain, temperature, and autonomic nervous function. Here's the first little nugget that came up that I was like, oh, okay. If you have pure small fiber neuropathy, that will not show up on a nerve conduction study. Nerve conduction studies are only good for large fiber neuropathy. So if you suspect small fiber neuropathy, you have to get a skin biopsy to diagnose that. And then with the time course or temporal course, really you're talking acute versus chronic. So if you have something like Guillain-Barré syndrome, and asterisk, I have no idea if that's the right way to pronounce that or not. I've heard it pronounced so many different ways. I say Guillain-Barré. If it's something quick like that versus something subacute, which would be in the 1 to 2 month kind of range, or something chronic, which is in the greater than 2 month range, that tells you something about the underlying cause. Of course, I'll put a link to my document that I'm referencing for this. There's a good figure out of JAMA in here that talks about the differences between sensory nerves, motor nerves, and autonomic nerves, and how neuropathy in those different nerves will present. So if you're talking about sensory nerves, this I think is what is commonly in my brain when I'm thinking about neuropathy. So this is where we see numbness or loss of sensation, paresthesia, that being tingling, burning, prickling. People will describe it as pins and needles, or feeling like their extremity is going to sleep, or whatever part of them is going to sleep. Ataxia, sensory ataxia. Some people will also describe frank pain. A lot of times they will say it feels like an electric shock, or it's a very stabbing kind of a pain. And then this can give you absence or reduction of deep tendon reflexes. The reduced deep tendon reflexes is also true for motor nerves. But when we see neuropathy affecting motor nerves, now we're thinking about muscle atrophy, muscle weakness, fasciculations. And then if we're talking about autonomic nerves, now we're talking about autonomic symptoms. So the patient's orthostatic, their mouth is dry, their eyes are dry. Early satiety, affecting the GI system, and constipation, urinary retention, erectile dysfunction, increased or decreased sweating. I will confess, I've probably never thought about, is this neuropathy affecting autonomic nerves? That's just not something that I am aware of. There's my second little nugget that I have learned already. And a lot of people do have weird autonomic symptoms that you can't really find an explanation for, although a lot of times they're on a medicine that's causing that. But that's a great little pearl to keep in mind. The other part of this graphic that I'm looking at is an explanation of how peripheral neuropathy actually affects the nerves themselves. And that would be that the neurons die, the axon degenerates, so you get a change in the excitability of that neuron, or you get Schwann cell dysfunction. So both of those things affect the nerve's ability to do its job. And as a reminder, if you look at a cross-section of a nerve cell, you have the larger nerve made up of little groups of smaller fibers, right, that are broken down into fascicles and then axons. So there are a whole bunch of axons in any given nerve. And with neuropathy, those individual axons are what start to die. So as far as etiologies of neuropathy, of course, diabetic neuropathy is the most common one, and that's worldwide, not just in Western populations. That affects up to half of people who have diabetes, identified as the fifth most common neurological cause of disability by the 2021 Global Burden of Disease Study. And I would say this is most commonly what I see in my practice. Apparently about 10 to 15% of people newly diagnosed with type 2 diabetes already have diabetic neuropathy by the time they're diagnosed. That sucks. I always think of hyperglycemia being the primary driving force of that, high glucose damaging the nerve cells, but they have also identified the other components of metabolic syndrome as independent risk factors for neuropathy, those being obesity, dyslipidemia, and high blood pressure. Here's something interesting. Here's another nugget that I learned doing this. Intensive glycemic control reduces neuropathy risk by 78% in type 1 diabetics, but hasn't really shown a lot of benefit in type 2 diabetics. How about that? In my brain, if you fix the glucose, then the neuropathy is not going to get any worse, but that is certainly not true for all type 1 diabetics, and apparently not true at all for type 2 diabetics because of those other risk factors, in case you needed more reasons to yell at people about diet and exercise. Here's something I learned that I don't even want to say out loud, because there is this conception out there that people taking insulin is what causes them to get their legs chopped off, but there is actually a treatment-induced neuropathy of diabetes, also known as insulin neuritis. This is an acute painful neuropathy that affects small fibers and autonomic fibers that's triggered by rapid correction in A1C, defined as a greater than 2% drop in 3 months. How about that? I bet I've seen that and didn't realize it. So that's diabetic neuropathy, and diabetic neuropathy affects large fibers if you're keeping track. When we talk about small fiber neuropathy, again, that's the one that is not going to show up on a nerve conduction study. Diabetes still causes about a third of small fiber neuropathy. Other causes of small fiber include autoimmune diseases like Sjogren's or sarcoid or celiac, hereditary causes including Fabry disease, transthyretin amyloidosis, and a long series of numbers and letters channelopathies, and infections including hepatitis C and HIV. However, in up to half of cases of small fiber neuropathy, the cause remains unknown. So we can console ourselves a little bit about the patients who float along with neuropathy and nobody knows why, because that's really pretty common with these situations. There's a chemotherapy-induced peripheral neuropathy. This is super common. I have multiple patients who've been through cancer treatment that have neuropathy that was caused by the chemo. This affects like over half of patients who receive neurotoxic chemotherapy, and in about 30% of those, it persists beyond 6 months. So the particular agents that are major causes of this include cisplatin and oxaliplatin, the taxanes like paclitaxel and docetaxel. Forgive me if I'm mispronouncing these. I definitely don't deal with these ever, other than seeing them in oncology notes. Vinca alkaloids like vincristine, I know I pronounced that right, and proteasome inhibitors, an example of which is bortezomib. Talking about inflammatory or immune-mediated neuropathies, of course, Guillain-Barré, I think we're all pretty familiar with. That's the classic ascending paralysis that can lead to having to be on the ventilator until it goes away. Here's a scary statistic. Despite treatment, about 5% of people with Guillain-Barré die, and about 20% remain unable to walk independently at 1 year. Yikes. I have a handful of patients that have had this for one reason or another, and I think all the people I'm personally taking care of have recovered from it, and it has not left too much of a deficit. The other common inflammatory or immune-mediated cause is CIDP, which stands for chronic inflammatory demyelinating polyradiculoneuropathy. Glad we have a abbreviation for that rolls off the tongue. This kind of neuropathy develops over at least 2 months, and you get these progressive or relapsing sensory motor kind of symptoms. There are several different variations and subtypes of that. And then we have hereditary neuropathies. This is like CMT, Charcot-Marie-Tooth. We did a whole episode on that with Dr. Todd Oyen a while back. If you haven't listened to that before, go back and listen to it. That was a fantastic discussion with Dr. Oyen, who's not only super smart and could tell us about it, but also has it personally. Clinical hallmarks of CMT include progressive distal weakness, atrophy, hammer toes, loss of reflexes, and pes cavus, also known as hollow foot, where you get this super high arch that develops. Some other important causes of neuropathy to think about are alcohol, present in almost half of people with chronic alcohol use disorder. The underlying physiology there involves both direct toxicity to the neurons from alcohol, from ethanol, but also nutritional deficiency, especially thiamine deficiency. B12 deficiency is a big one that I always think about. I try to make sure to check everybody that has neuropathy symptoms for B12 deficiency. Big risk factors for B12 deficiency would be, of course, pernicious anemia, bariatric surgery, people on metformin, and nitrous oxide exposure. I didn't know that. That and iron deficiency I've been trying to check for a lot more often lately. Iron deficiency, as far as I know, doesn't have anything to do with neuropathy. It just popped into my brain, but that is something I'm trying to check for a lot more often, because I think those are things that we often overlook if the patient's not anemic, right? Or if their MCV is not off on the blood count. And finally, monoclonal gammopathies. Specific syndromes there include anti-MAG neuropathy, POEMS syndrome, and AL amyloidosis. There's a good table here from AAFP that's very long, so I'm not going to read it, but if you follow the link in the show notes to the resource here from Open Evidence, it has all these different etiologies laid out by the pattern of things that are involved. That would be super useful if you're dealing with one of these situations and weren't sure about risk factors or how it was presenting. It's just called Etiologies of Peripheral Neuropathy by Pattern of Involvement, and it's labeled Table 1. So as far as clinical manifestations, symptoms, we've pretty well hit this already. Red flags that should make you think about this more urgently include asymmetry of neuropathic symptoms, non-length dependent distribution, so I take that to mean more proximal distribution of the symptoms, motor predominance over sensory, of course if it's a quick onset, and autonomic involvement being the predominant problem. those folks definitely need to get a more urgent and more complete workup than your typical, I've had some tingling in my foot for the past 2 years or whatever. So, how do we diagnose this? As with most things, the history is going to be your most important component. Of course, we want to know what it feels like, how long it has been occurring, the distribution of it, and then if they have any obvious causes or potential risk factors that would point you toward a particular type of neuropathy. Obviously, if they're diabetic, would be the most important question to ask there. But also exposures to medications or toxins like the chemotherapy drugs we mentioned earlier, comorbidities like the metabolic syndrome we mentioned, family history, if anybody has a history of course, known neuropathy, but also any kind of foot deformities or childhood clumsiness. That's a very specific symptom. I guess that would point you towards something hereditary. And those autonomic symptoms, which may be way more subtle and, at least in my brain, would not trigger the neuropathy pathway. And of course, on your physical exam, this is just assessing all the different nerve functions, all the different neuro exam components. So we're trying to be systematic about checking pinprick and temperature sensation, which would lead you down the small fiber path, vibration and proprioception, which leads you down the large fiber path, and then strength, reflexes, gait, etc. Lab tests not super useful for just neuropathy itself, but of course we are using lab tests to look for common causes of neuropathy. So obviously the most important would be the blood glucose or the A1C. Also SPEP with immunofixation, that would lead you down the monoclonal gammopathy route. SPEP is one of these terms that the light goes off in my head that says, hematology, you're not smart enough for this. Refer. That and light chains trigger that warning light in my head also. And then serum B12 would be the other thing to check commonly. If you're going to check a broader panel looking for causes of neuropathy, that should include a blood count, metabolic panel, TSH, and additional tests based on the situation might include HIV, Lyme disease, ANA panel, ANCA, ACE level. That's angiotensin converting enzyme, as in the thing that's inhibited by ACE inhibitors. That helps you rule out sarcoidosis. Heavy metals, paraneoplastic panel, anti-MAG or anti-ganglioside antibodies, and genetic testing if you suspect a hereditary situation. Again, with electrodiagnostic studies, we're talking nerve conduction study or electromyogram, EMG, but keep in mind that's only for large fiber neuropathy, and that can help you distinguish large fiber neuropathy from radiculopathy or myelopathy, and that can also help classify it as either axonal or demyelinating. If you come up with a demyelinating cause, that really narrows the differential down to either CIDP, CMT, or anti-MAG neuropathy. So that's a very helpful finding. Figure 2 in this reference document is from JAMA. It's a good little algorithm for evaluating peripheral neuropathy. And what do we do about it? How do we treat it? There's not really any aces up the sleeve here. I don't mean angiotensin converting enzyme. I mean the card, the ace up the sleeve. Pretty much you got tricyclics, you got SNRIs, and you got gabapentinoids. Obviously, those all have their issues. Tricyclics, that's going to be like amitriptyline or nortriptyline. SNRIs, that's duloxetine or venlafaxine. And then gabapentinoids are gabapentin or pregabalin. I find just in my personal anecdotal experience that gabapentin probably works the best for neuropathic pain. I do use duloxetine a lot as a second-line agent or for people who cannot tolerate gabapentin for whatever reason. Tricyclics I tend to save for the last option. True second-line agents, other things that can help include topical capsaicin. Nobody's ever heard of this. I do mention it to people pretty frequently, and nobody's ever heard of capsaicin ointment. As far as results from that, anecdotally, I find that most people don't find it super helpful, but every once in a while somebody will come back and say that they thought it was helpful for nerve pain. And then topical lidocaine can be an option. True third-line agents include Botox, opiates, and TMS, transcranial magnetic stimulation. That's kind of an exciting thing that's come along lately. There is some data that suggests combination therapy with these medications is more effective than monotherapy, which kind of makes sense since they're all different or somewhat different mechanisms. And obviously, depending on the situation, whatever the underlying cause is or risk factors are, if you can do something to improve or modify those, that's what you want to aim for. In my experience, neuropathy doesn't really seem to get better, but hopefully we can do something to stop it from getting worse and manage the pain. As far as actual disease-modifying therapies that are available for CIDP, of course, you have IVIG, steroids, and plasma exchange available. And the numbers on that are pretty good, about a 50 to 80% chance of things getting better with any of those therapies. There are some novel medications called FcRn inhibitors, an example being efgartigimod, that are under investigation for that. Guillain-Barré, similar. Of course, you have IVIG and plasma exchange. Steroids alone are not super helpful for that. There's nothing you can do for diabetic neuropathy other than control all the risk factors and manage the pain. Some guidelines do recommend trying alpha-lipoic acid, but not all guidelines. And non-pharmacologic things we can recommend would be exercise. There's not much that exercise isn't good for. And also spinal cord stimulation. There is some thought on the horizon that GLP-1s and SGLT2s may have some neuroprotective effects. Of course, they're good for everything else. Why not neuropathy? I have seen some neuropathy clinics kind of popping up. There's one here where I live called Revolution, like revolution except with a B. They do some kind of outside of the box treatments that I think are FDA. I always get this terminology confused. They're like FDA cleared things that they use. I'm just looking at their website, which I'll put a link to. It says they use targeted light therapy, neuroelectrical stimulation, regenerative technologies like soft wave, and nutritional protocols. I have one patient who has done this and found it helpful for his neuropathy symptoms. I have one other patient who went and said, oh, they just want a bunch of money up front, and I didn't get a good vibe. So those are my N of 2 experiences with this place or this kind of treatment center. When I first heard about this, of course, I assumed it was complete BS, that they were just charging people a lot of money to give them gabapentin or whatever, but they do actually have some alternative therapies, so it seems there's not a lot of evidence behind that, so I can't say one way or another that it works definitively, but there are other options out there if patients want to pursue that on their own. Not covered by insurance, I believe, and from what these two people have told me, somewhere in the several $1,000s range to go through their treatment program. And I think that's all I have to say about neuropathy. I definitely learned some stuff. I hope you did too. I hope this was useful for you. You know, I'm going to plug this book I wrote. If you haven't bought Crooked Creek Serenade yet, check it out. Read it. I'm very proud of it. I think it's very good. If you're following me on Instagram at Jody Marks Writes, I am on there. I am on there more than I've ever done anything on social media before. I'm trying to push this and make something happen with it. So if you're so inclined, please support me on that, whether that's by following my Instagram, sharing my post, getting the word out about the book, purchasing the book, reviewing it, rating it, sharing it with your friends. You could purchase multiple copies of the book if you would like. Christmas is how many months away? So anyway, there's that. As always, thank you for listening. I hope that you have a great week, and I will talk to you later. All right, that does it for this episode of Knowledgeable Provider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, and subscriptions really do help the show, so please take a second and do those things to help me out. If you have a request for an episode topic, or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order. Which stands for chronic inflammatory demyelinating I almost made it.